Good afternoon, and welcome to the latest installment of the Chicago Asthma Consortium's Lunch and Learn series. Today, we're going over the findings of the Chicago Asthma Consortium white paper on implementation of smart therapy. Um, Thank you all for being here today. It's great to see such a large group of participants. Please mute your microphones, and you can also hide your video. You won't need you won't need either of those for today's presentation. Um, okay, next slide. Oh, it's me. All right. I'm today's moderator. My name is Matt Seymour. I'm the president of the board of the Chicago Asthma Consortium. I'm also the executive director of Mobile Care Chicago. We have mobile units that travel around Chicago, the south and west suburbs, and then into Lake County to provide free medical care for people. And for 25 years, we've had asthma vans that have traveled around the city, and we provide free ongoing specialty care for kids who have asthma and allergies. I'm also a person who has asthma, so I am personally very passionate about asthma issues and today's topic. And next slide, please. So for today's schedule, we're going to do a brief overview of the Chicago Asthma Consortium, and I'll introduce our speakers. I'm very excited to have these two speakers here today. We'll go through the presentation, and then we'll also have a question and answer session afterward. And we'll try to close promptly at 12:30. Next slide. A couple of housekeeping items. So video and audio should be off. You won't need either of those during the webinar. If you have technical difficulties, you can contact Kay in the chat. We encourage people to network and say hello in the chat. So please introduce yourself and feel free to put comments into the chat or to ask questions as we go along. If you do ask questions, I will aggregate those and then I'll make sure that they get asked to our presenters at the end during the Q&A session. So anytime during the presentation, feel free to put a question into the chat if you have a question. And then once the presentation is over, you'll see a link go out in the chat that'll be an evaluation for the webinar. This is really important information for us. This is how we make sure that we continue to offer topics that are relevant to you and just help us to create really good processes that get you the information you want in a way that's useful. So please do fill out the survey. We do take those seriously and we read them. Next slide. A little bit about the CAC. So our mission is to improve the quality of life for people who are living with asthma. And we do that through advocacy, education, and collaboration. And the collaboration component in particular is where CAC really is the convener for the city of Chicago, bringing together business leaders, government agencies, community-based organizations, and individuals, both those who have asthma and those who support people who have asthma, in raising awareness for asthma as a condition and improving the life of people who have asthma. If you want to join us, you can become a member or you can contribute at chicagoasthma.org. Next slide. And other ways you can help. So Chicago Asthma Consortium is a network of volunteers. So it's just a bunch of us who either work in asthma issues or who are living with asthma, who come together on a number of topics to try to get resources out to people. So we have a community advisory board that helps to provide feedback on research projects. We have a community engagement committee that helps to educate people in the community about asthma. We have a fundraising committee, a membership committee, and then we have a professional development committee, which is the committee that puts on presentations like this one. We are also accepting applications to join the board. So if you're interested in that, you can contact info@chicagoasthma.org for more information. You can also connect with Rochelle, our executive director, in the chat, and she can talk with you more about this process. But we would love to see you in any of our committee work or on the board of directors if you would like to join there. Next slide. Today's presenters, like I said, I'm really excited for this presentation. I've been looking forward to it. So I will provide a brief introduction of our two presenters. The first is Osuji, who is an MD, MPH candidate at the University of Illinois at Chicago College of Medicine and the Harvard T.H. Chan School of Public Health. Her research expertise lies in quality improvement and health services research, aiming to improve healthcare access, quality, and delivery to achieve better health outcomes. With a deep passion for health equity, she is dedicated to developing her expertise in designing and innovating equitable patient-centered healthcare systems, and is also an urban medicine scholar and serves as the Clinical Algorithms Committee of the Jesse Brown for Black Lives Task Force at the Jesse Brown Veteran Affairs Medical Center. So welcome, Anne. Our second presenter is Aashna Shah, who is a second-year medical student at urban medicine scholar at the University of Illinois College of Medicine. She graduated from Case Western Reserve University, where she earned her Master of Public Health with a concentration in Health Policy and Management, and a Bachelor of Arts in Medical Anthropology on the pre-medical track. Her research interests include health disparities, reproductive justice, and food insecurity. So welcome, Aashna, as well. It's wonderful to have you both here, and I'll pass it over to you to get the presentation started.
Great, thank you, Matt. I will go ahead and share my screen. All right. It was great to be introduced by you, Matt. Thank you so much. My name again is Anne Osuji. I'll let my co-presenter also introduce herself.
Hi, and I'm Aashna Shah.
It's great to have you guys all on the call today. We are presenting on smart therapy. The title of our presentation is Addressing Barriers to Implementation, and we'll be discussing some findings from the CAC white paper. So to begin our presentation today, we have a couple of learning objectives that we want to leave you all with. First is to review the latest guidelines and recommendations around smart therapy, summarize key literature on the efficacy of SMART and its clinical outcomes, discuss the challenges and successes of implementing SMART from a provider's perspective, and then lastly, we'll leave you all with practical recommendations for integrating SMART into clinical practice. There we go. So SMART therapy, otherwise known as single maintenance and reliever therapy, combines a maintenance medication, which is usually an inhaled corticosteroid, and a reliever medication, so a long-acting bronchodilator, into a single inhaler. And traditionally, asthma therapy involves having a maintenance therapy in one inhaler and a reliever in a separate inhaler. But with SMART, it allows patients to use one inhaler for both. So it really consolidates the therapy regimen. It's typically indicated for the management of moderate to severe asthma, including those who frequently experience symptoms or exacerbations. And right now in the US, it comes in two formulations, Symbicort and Dulera. As you can see on the slide, Symbicort and Dulera both have the same long-acting bronchodilator, which is formoterol. They just have different corticosteroids. So in Symbicort, they use budesonide, and Dulera, they use mometasone. In most of the asthma guidelines around SMART therapy, the budesonide-formoterol combination, or Symbicort, is the recommended first-line treatment for the treatment of asthma with SMART therapy.
So SMART represents a deviation from the traditional model of asthma management using both the separate maintenance and reliever therapy. So in 2021, the guidelines from the Global Initiative for Asthma, or GINA, were updated to include SMART as the preferred therapy for patients who are at steps 3 or 4, in other words, moderate or severe asthma in the stepwise model for asthma care. And within the GINA guidelines, this was specifically done for patients who were above the age of 12 years old. So SMART was not recommended for patients in the 4 to 11 age group. And this was a major shift from prior management with the separate maintenance and reliever inhalers. Next slide. And then in 2020, the National Asthma Education and Prevention Program, or NAEPP, also introduced similar changes. So the guidelines remain similar for patients over 12 years of age, with the SMART being recommended for patients with moderate and severe asthma, but differ for management of patients within that 4 to 11-year age group. For these patients with the NAEPP guidelines, SMART was recommended at step 3 with moderate asthma.
So to answer the question, why the big change? First, it's important to look at the pharmacotherapeutic benefits of SMART therapy. It essentially would provide dual action airway response, including anti-inflammatory coverage during symptom flare-ups that would come from the inhaled corticosteroid. And this ensures that patients receive both immediate relief from the bronchodilator as well as long-term control from the steroid in a single inhaler. Another very major benefit of having this one inhaler therapy is just a simplification of the medication regimen itself. SMART therapy can take away some of the confusion about which inhaler to use and when for many patients, which in turn can improve adherence, especially amongst children or elderly adults or anyone with any barriers to medication adherence. And then lastly, the safety profile is more favorable with SMART therapy. It involves lower overall doses of inhaled corticosteroids compared to the 2-inhaler regimen, and this would reduce the risk of side effects. And then on a larger scale, it would improve healthcare costs related to asthma exacerbations by reducing emergency room visits and hospitalizations. So overall, there are advantages to this model of therapy, but there does present some barriers to implementation, which we will discuss later in this presentation. So the start of our journey on this project began with a review of the literature. We looked to see specifically what the scientific community was saying about SMART therapy, its effectiveness, and its implementation. And regarding its effectiveness, there have been a number of trials and reviews that affirm that SMART is a superior management therapy, particularly in terms of its better asthma control, its reduced number of frequency of exacerbation for patients, as well as increased QALYs or quality adjusted life years for patients living with asthma. And then with regards to implementation, however, there have been limited but published research on the barriers to implementation, which largely include a lack of provider awareness, lack of FDA approval, and inconsistent insurance coverage, with some facilitators noted including patient satisfaction with using a single inhaler. So the adoption of SMART in the US remains to be limited due to these specific barriers, which highlights a need for greater awareness and advocacy of SMART as a therapy.
So in conducting our literature review, we did notice some gaps that were present in the literature. As Anne mentioned, since adoption of SMART in the US does still remain limited at this point, there is a lack of documentations on things like prescription patterns and just generally little information available about implementation at this stage and how that rollout has happened. Also, as is reflected by the guideline changes mentioned earlier, there is still limited research available on SMART for children ages 4 to 11 years old, which is why certain guidelines do not yet recommend SMART for this age group. And then also with the scarcity of implementation information available, we have limited data on provider perceptions of SMART, and also some of the clinical implications of SMART implementation in the primary care setting. And so to kind of look more into these provider perceptions, we conducted our next stage, which was our provider interviews. Thank you. So in addition to the literature review, we interviewed numerous local providers within primary care, as well as specialists that care for patients at different age groups with varying levels of asthma severity. And through these interviews, we gained a lot of insight into several different themes mentioned here. So we learned a lot about provider knowledge and beliefs around SMART, barriers within clinical practice, and then also facilitators and things that allowed for further self-efficacy among providers. Next slide. So in regards to knowledge and beliefs, providers expressed varying levels of awareness with the guideline updates around SMART, and also varying levels of comfort with actually utilizing these changes in practice. So we heard from several providers who were affiliated with an academic institution that often the way that they heard about SMART was actually via a medical student or a resident that brought up these guideline changes to them, and they expressed some concern that people outside of that academic sphere may not have as much exposure to information about these guideline changes. However, all of the physicians that we spoke to believe that SMART presented many advantages as a new model for asthma treatment. And so some things that were mentioned were the ease of using a single inhaler for patients, and mentioned some of these benefits earlier in terms of adherence and avoiding some of the confusion within patients. And providers thought that this was especially true for pediatric patients, as well as patients who might have lower levels of health literacy. Also, providers mentioned that SMART presents a benefit for treating some of the intermittent aspects of asthma, since patients are now receiving not only a bronchodilator during those periods of symptom exacerbation, but also this anti-inflammatory component with the inhaled corticosteroid at that time as well. Next slide. And then in terms of barriers, the largest barrier across the board that physicians identified was insurance coverage. So since Symbicort and Dulera are not yet FDA approved to be used as both maintenance and reliever therapy in the form of SMART, insurances will not typically cover the multiple inhalers that patients may end up needing if they're using the inhaler for both purposes instead of just as a maintenance. And this ends up delaying care for patients, and then also creating an additional obstacle on the provider end as well if they need to adjust the prescription or the therapy that the patient is receiving if they're denied that at the pharmacy. There's also a lack of consistency in education around SMART, as healthcare providers across different settings may not be equally aware of SMART and may start a patient on a different therapy regimen if they're in a different setting. Education within schools is also a barrier, since some schools may require students to have albuterol on hand, and school nurses may have varying levels of comfort and knowledge around SMART too. Additionally, patient comfort with albuterol was a common barrier, since patients are used to the quick relief from albuterol when using it as a rescue. They might be uncomfortable with switching to a model where they use their maintenance therapy for that relief during symptom exacerbation. Next slide. And then on the other hand, providers did also express certain factors that made it easier for them to familiarize themselves with SMART and prescribe it in their setting. So providers that worked in clinical settings that had integrated the guideline updates into their EMR reported that this made it a lot easier for them to handle management plans across different age groups and varying levels of asthma severity. And it also served as a good form of reinforcement for them as well, to remind them that these new changes were in place. Access to SMART-specific asthma action plans also made asthma management with SMART easier for providers, especially with pediatric patients who may require these asthma action plans within schools as well. They also found that it was at times easier to initiate or switch patients within the teenage age group to SMART, since they might have less exposure to using a separate maintenance and reliever therapy at that point, and a stronger preference for utilizing the single inhaler management model because of the ease of just carrying around that single inhaler.
So with the expertise of many providers that we interviewed, as well as our literature search, we came up with a few actionable recommendations for those who interface with people living with asthma on a daily basis regarding their smart therapy and how we can overcome some barriers to implementing the therapy as a whole. Largely, it's to increase education about SMART. One of the primary barriers to implementation that Aashna discussed is provider awareness. And so I think this is a call for more of a rebrand for asthma treatment. I know the two inhaler system has been around for a long time, and people have been living with asthma for also a very long time, but smart therapy has a lot of benefits that can provide patients. And so having that strong educational component can really help us shift the brand that asthma treatment has currently. And then again, education between primary care providers and specialists. Oftentimes, the transition between primary care providers and specialty care providers can cause a bit of confusion with therapy management. So having a solid front for patients can make them a lot more comfortable. And then, like Aashna mentioned, the development and implementation of new smart asthma action plans, especially for the pediatric population that require these plans across settings. There's a picture here on the slide of an example from the Allergy and Asthma Network. These plans can facilitate shared decision-making with families and also continuity of care, again, between settings like home, school, and elsewhere.
So we wanted to leave you all with a call to action and look at how we can standardize smart uptake across clinical settings. So in order to have this guideline concordant practice that we're aiming for, some strategies that we can look into are integrating the guideline changes with EMR, as mentioned earlier, and also reinforcing them in the clinical setting through whatever platform updates are regularly shared, whether that's in morning huddles, all hand meetings, or grand rounds. Additionally, equipping asthma educators with updated knowledge around SMART can also help spread the word about guideline changes among patients as well. And there's additionally a need for more patient-facing materials for clinicians to have on hand when they're providing patients with education around SMART and how to manage their asthma. And so this can be a major facilitator in allowing for greater patient understanding and adherence to the treatment. And as we mentioned earlier, SMART does represent a large shift in what was once the standard practice of prescribing a single maintenance and reliever therapy. And because of this, it's incredibly important that both patients and providers receive the education and these resources needed to put this change into effect more broadly. I think.
And thank you all for listening. Here are our resources, and we will relay the rest of the time for questions. But first, we wanted to acknowledge Dr. Rabat and Dr. Volerman for their expertise and support during this project, as well as Rachel Paul Brutus for her support as well. Thank you so much.
Thank you both for this presentation and for all of the interviews that you did to aggregate this knowledge base. And I'll just say, if anyone has any questions, feel free to put them in the chat. We have a couple minutes where we can ask a couple questions. One that I'm interested to hear you all weigh in on that you kind of touched on was this sort of this potential disconnect between folks who are doing asthma and allergy every day and primary care providers who, also are managing asthma pretty frequently, but might have a lower awareness level of what smart therapy is. Or if they have heard of smart therapy, it might be in a context in which they feel like implementation of it is like fairly limited, so much so that they don't bother implementing it for the vast majority of their patients. So I wanted to just sort of ask, like, in your interviews, did anyone bring up any sort of like potential solutions for this? Because I know of a couple examples off the top of my head where primary care providers have modified our treatment plans because they didn't understand what we were doing. And so they end up putting a different set of medications into the mix, and patients get confused, and ultimately it potentially affects their quality of life. So just wanted to hear if anyone had sort of expressed any ideas about how to interface with primary care providers better.
I think one thing that was definitely mentioned is that EMR change as like reinforcement. So having that available and kind of populating in a plan can make it easier for the primary care provider to have an easy route to then prescribe smart to their patients. And then the other thing was also just patient education. I think there were some providers that mentioned that because of their own level of comfort with smart, they may or may not be struggling with the patient education component. There might be some confusion left on the patient end, whereas others mentioned that there was very good patient response to smart, and so potentially equipping providers with like resources so that it can be easier for them to then kind of jump that barrier of patient understanding could also be another route. I don't know if Anne, you had anything else.
One thing that really jumped out to me when I spoke with a few providers, especially pediatricians, was the concept of getting insurance coverage. I think the main hindrance is that a lot of insurances would only prescribe just that one single inhaler for a month. And so if you run out of the inhaler or you need it for different settings, in the case of smaller children, that like kind of affected their comfortability with switching a patient who was already on traditional therapy. And so, I mean, we're still ideating on what are the best solutions across age groups, but a lot of providers mention that these are the things that keep them from feeling comfortable from even educating their patients with the little that they do know.
Yeah. And we have a question from Christina. Is your data published already?
Not yet. These are the preliminary findings that we hope to at the conclusion of our paper.
Okay. And when a patient uses smart therapy, this works in green, yellow, and red zones, is one of the questions that we got.
By the zones, are you referring to like different steps of asthma severity?
I think they're talking about the asthma action plan. The traditional
Oh,
one has like a, like green, yellow, and red for like your different action steps you're supposed to take. And typically it's broken down into like your control medications, your relief medications, and then like some information about like seeking urgent medical help if you need that. So I take it that they were just asking if like the asthma action plan itself needs to be modified to accommodate smart therapy.
yeah, that's so it does need to be updated. The one we actually have in the PowerPoint is an updated version that incorporates Smart, and so it has been updated and modified to reflect that. And I believe it should be posted on the CAC website soon as well for your references.
Yeah, the link is also in the chat as well to the specific asthma action plan that was in the PowerPoint. But that's a great question.
Perfect. And um, Lynn Sullivan had put some really great stuff in the chat, and I'll it's it's not really a question, but I just wanted to point to it because I think that this learning group, Lynn, that you're talking about is exactly what we need to have more of here. So thank you so much for sharing. Um, and we have in the 1 minute that we have remaining, I'll just put in a plug again. If you can send your feedback in with the survey, we have some upcoming events, and we'll have another series of Lunch and Learn presentations in the spring. And any sort of topics that you want to know about, we'll aggregate those, and then we will find experts who can talk about those particular topics. So please do fill out the survey and make sure that if there's topics you want to know about, that's well understood. In terms of upcoming events, we have a virtual conference coming up on November 15th where representatives from the city of Chicago, Cook County, and the state of Illinois will be presenting on the latest asthma data that they have available. And then we'll be facilitating discussions about what that data means. So I would highly recommend that any of the folks who are here for this presentation also join that meeting. This is the first time that we'll have a presentation like this since 2022. So it'll be really good to see what the latest data says, and then also to digest that and come up with our next action steps. So with that, I think we're going to have to end the presentation today. Thank you so much for attending. Take a moment to fill out the survey. And if you have any other questions, you can always email info@chicagoasthma.org. So thank you, Aashna and Anne, again, for your presentation, and wonderful job. Thank you for joining us.